Hi there, at MCTA Eric here today doing some mobilization with movement techniques, and also known as the Mulligan concept techniques. We've had some requests online for some clarifications as well as just more videos so people can share these in applications with other clinicians as well as their patients. So the first one we're going to start with today is a reverse NAG. NAG is an acronym that stands for Natural Apophyseal Glide. We're well aware that mechanisms of how these are effective are highly in question, but we're going to take in all the considerations of what might occur during this and explain them as we go through the technique. So we're going to start with the patient in sitting. We can take a pillow and put this underneath their arms so their shoulders are more at rest. Tuck it in, there we go. When we discuss the arthrokinematics of the upper thoracic spine, we also have to consider that these facet areas are a little bit more vertical than, let's say, the mid-cervical spine. So I'm going to have Megan slide her hips forward in the chair, and creating a little bit more of that kyphotic posture allows me to acquire a nicer purchase when I do this mobilization here. What's different with this mobilization compared to most standard mobilizations is that we're going to be in a weight-bearing functional position for the patient rather than putting them in a dependent position on a table. So I'm going to stand to the side and I'm going to use a wide-based key grip. So this is your standard key grip as normal, where the thumb pulls into the index finger and the index finger is completely flexed. What I'm going to do is widen that out so that there leaves room for the spinous process between my finger and my thumb, and one contact is on one transverse area and the other contact is going to be on the other transverse area. We also have a unilateral contact that we can go through. So I'm going to hold on to the patient's head, and this allows me to position her into flexion or extension a little bit, but also gives me control, as this is an oscillatory mobilization and can create force through the body. So I'm going to get this contact behind the patient. I'm going to be pushing in and then dropping my elbow to slide up. Okay. So as I create contact here, drop and I slide up. Once I have an end point, then I can oscillate in that plane 2 to 5 oscillations per second. These are standard graded oscillatory mobilizations, and we can go as long as you deem appropriate as a clinician. I can always have equal pressure, or I can create pressure on one unilateral side more than the other. My unilateral contact is a double finger flexion on one side, but same, I glide up to an endpoint, and then my oscillation comes up from there. Other considerations are having my belly against the patient's shoulder. That creates further contact and stability for the body so they're not flopping around. This area is really common to have a little bit of extra oil on it from hair, especially for females. So we can grab what I started using now, which is a motion guidance contact pad. This allows for a sticky, grippy surface and is also hygienic. You can wash these after you're done with soap and water and get rid of any skin cells that might have been on the area. But doing the same mobilization really allows me to get a nice extra purchase here for the mobilization. It also creates a cushioned surface. If your contact is sore for the patient, it'll lighten that up. And that's a reverse nag. We classically use reverse nags for in-range loss of motion through the neck or CT junction dysfunction. Thank you. Hopefully this adds some clarification to some of the techniques that we discussed today. I hope to see you next time and on future techniques and videos.